Good afternoon, everyone. I am Dr. Winston Wong, Chair and Acting CEO of the National Council of Asian Pacific Islander Physicians, and will serve as the moderator for this session. This session being How Health Equity Can Drive State, Territorial, and Tribal COVID-19 Response. We have our disclaimer slide, if you can just look at that very quickly. I did want to provide you with a few housekeeping items before we get started. If you hold MCHESS status and did not submit your ID number during registration, please submit your name and ID number to virtualsim lowercase CEUS at minorityhealth.hhs.gov to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute, and please post your question through the Q&A corner icon at the top of the screen for responses from the speakers. Due to limited time, not all questions will be addressed during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following this presentation. So next slide. It is my pleasure to introduce our panelists. Our first panelist, Sandra Brown, DNS, APRN, FMP, board certified, CNE, ANEF, FAANP, FAAN, Dean and Professor, College of Nursing and Allied Health at Southern University and AMN Baton Rouge. She's also the co-chair of the Louisiana COVID-19 Health Equity Task Force. Dr. Brown has achieved international prominence and made enduring contributions to reduce minority health disparities and improve social welfare. The breadth of her work has spanned over 2 decades, impacting the health outcomes of Louisiana citizens through her clinical research, practice, and academic leadership. She is nationally recognized for her exemplary work in promoting access to healthcare for the medically underserved and for her outstanding contributions during disaster recovery. In April 2020, Governor John Bel Edwards appointed Dr. Brown to serve as co-chair of the Louisiana COVID-19 Health Equity Task Force, leading the efforts to address health inequities that are affecting communities that are most impacted by the coronavirus. Our second panelist, Darielis Cordero, MPH, Director of Special Programs at the Puerto Rico Primary Healthcare Association. Since 2016, Ms. Cordero has worked as a director of the special programs for the Puerto Rico Primary Care Association. A strong epidemiologic and data analysis formation, previous experience working in the healthcare system, and her strong leadership has served as her tools to guide coordinated, strategic, and sustainable response to public health emergencies and natural disaster emergencies. She has been a liaison with federal, state, and non-governmental entities supporting emergency response and recovery and integration of clinical quality programs provided by health centers. Most recent achievements include innovation in the Women Health Services programs, family planning services expansion, and the integration of health center services with Puerto Rico Department of Health, nonprofit organizations, and federal programs. The objective of this session, How Health Equity Can Drive State, Territorial, and Tribal COVID-19 Response, is to highlight state, territorial, and tribal perspectives and recommendations for applying a health equity lens to COVID-19 response efforts. So without further ado, let's get started.
Thank you. Thank you for that introduction. And it is my pleasure to be here to present to you an update on the Louisiana COVID-19 Health Equity Task Force. Before I do that, I'd like to thank our governor, John Bell Edwards, for appointing a COVID-19 Health Equity Task Force for our state. He took action early on when he first was aware of the alarming high rates of COVID-19 deaths among African Americans, and he heard our voices and he took action. So we are very appreciative to our governor for this appointment of the task force and our call to action. The charge of the task force was to provide recommendations as it relates to health inequities in the state of Louisiana. We also are going to examine opportunities that are going to provide greater access to high-quality health care and improve health outcomes. Just to give you a little backdrop about the state of Louisiana, we rank 49th in the nation as one of the least healthiest states. We flip-flop between Mississippi and Louisiana. Mississippi is one of our neighboring states. But this is nothing new. We have held this ranking for decades. We also have very poor rankings as it relates to diabetes, hypertension, and obesity. And we also rank third in the nation for poverty. So Louisiana has some challenges. Louisiana has had these health disparities for decades. The novel virus, the coronavirus, shined a bright light on our disparities that have existed for years. So our goals and our outcomes from the charge is to provide reliable data as it relates to COVID-19 safety and prevention. We also are going to address the health disparities, the testing availability, and ultimately end up with producing a statewide dashboard on health equity. We are a fairly large health equity task force. We have 18 members that serve on the executive task force. I serve as co-chair alongside my co-chair, which is Dr. Thomas Leviste. He's dean of the Tulane University of the Public Health and Tropical Medicine Department. And we have, I'm just going to briefly show you the structure of the executive committees. These are members of the executive committees. And then we have over 45 members of subcommittee members. And these are subject matter experts who provide valuable information and have worked very diligently to move our charge. And I'm just going to briefly transition each slide to show you the different members of our subcommittees. Okay, so what we did, we thought that this was an opportunity for us to make meaningful change in Louisiana, not only in light of COVID-19, but for decades to come. So the task force met and decided on 9 priority areas that they would address and focus on as our task. We looked at COVID-19 testing for vulnerable and at-risk communities, communications and messaging, data and analysis, the health equity dashboard. We also wanted to address special populations, Louisiana prisons, nursing home residents, regulatory affairs, community outreach and stakeholder engagement, and racial disparities. So these are our 9 priorities that we have been addressing with COVID-19. We know that this year, 2020, is the year that changed the world, and so we felt that we wanted to capitalize on the movement and not make it just a moment. So looking at COVID-19 testing for vulnerable and at-risk populations, this subcommittee addressed the 3 T's: testing, tracing, and trending. We provided input into the statewide testing plan before it became public, and we addressed those barriers as it related to testing, particularly in vulnerable populations. So the task force was able to provide input on where the COVID-19 testing stations should be, removing those barriers. At one time, you needed a physician order to do testing. We wanted to remove that anybody who wanted to get testing could get testing. We mobilized mobile units and had them housed in locations where high population rates of COVID-19 were present. And so we wanted to make sure that anyone who wanted to get testing could, and it could be a walk-up type of testing. So we have been successful with those endeavors. The second priority subcommittee addresses communication and messaging. As it relates to communication and messaging, we felt it was very important that public health begins with public trust. So we wanted to ensure that the message was relatable and that the individuals who were delivering the message could be someone relatable to the community. We developed a social media platform. We looked at cultural relevant messaging. We also recommended street campaigns to incorporate youths in our messages. We integrated social media, Facebook, Instagram, Twitter. And currently, we are placing digital billboards throughout the state of Louisiana, from as far north as Shreveport to as far south as New Orleans, so that we can disseminate relevant messages. We've also translated those messages to other cultures, the Latinx, the Asian community, and Native Americans. And the TV commercials that we have produced have targeted how to wear a mask safely and correctly, and we are also in the preparations of preparing myths about vaccines. The next subcommittee is data and analysis, and this committee looked at key metrics based on race. Early on, 32% of Louisiana population is Black. However, 60% of the deaths from COVID occur among the Black population. So you can see that there is a disproportionate in the death rate. So we were very interested in looking at data as it relates to deaths by age, race, and zip codes. We felt that it was very important that we knew specific zip codes, because zip code is the most potent predictor of health and well-being. Zip code is more important than someone's genetic code. And if you could tell us your zip code, we could identify what was in your neighborhood, if it was a healthy neighborhood, basically looking at those social determinants of health. So where people are born and where they live should not determine whether they live. And so we felt it was important for us to get accurate data and to get data that was zip code based so that we could really target our interventions. The Health Equity Dashboard is the next subcommittee, and that committee is addressing the development of a health equity dashboard. Other states have it. We have looked at what other states are using, and we're in the process of designing and developing a health equity dashboard. We've contracted with PolicyLink and MySidewalk to develop the metrics that will go into this dashboard, and we're building it under the platform of social determinants of health and political determinants of health. We want the dashboard to be mobile, easily accessible anywhere, anytime, and for it to be able to tell the right story to engage our audience. And so that is the work that is underway as it relates to the Health Equity Dashboard. Special populations. We thought it was very important for us to look at vulnerable populations, and we targeted Louisiana prisons and nursing homes. In regards to Louisiana prisons, we wanted to gain information on what the state is obliged to do. We also recommended a comprehensive plan to address safety and prevention in Louisiana prisons population, and to also look at data. The data as it exists now in Louisiana is aggregate, and so we wanted to make sure that we can look at data that is disaggregated as it relates to positive cases, based by age, gender, race. We also are looking at CDC compliance with COVID-19 management in these correctional facilities. Nursing homes, residents, another vulnerable population. In Louisiana, nursing homes accounts for 40% of all COVID deaths. So we felt that that was very significant. We recommended that residents and staff be tested regularly. Currently, no visitors are allowed in nursing homes. We're hoping that at some point that could be loosened, and we thought that by having a strategic plan for doing frequent testing among the staff and the residents could offer that. We also recommended a comprehensive plan to address safety and prevention in nursing homes, and we looked at parishes where COVID deaths were highest and made recommendations as such. The next subcommittee is the Policy and Regulatory Affairs Committee. This committee is recommending policies and regulations to state legislature, one of which is a policy that has been recommended has to do with removing restrictions for advanced practice registered nurses, our nurse practitioners, so that they can practice to the full extent of their education. Right now, nurse practitioners have to have a collaborative practice to practice under a physician, but during COVID-19, that restriction was released. And so we felt that moving forward, that we should revolutionize healthcare in Louisiana by moving towards removing this restriction. And so we have made that recommendation. We also know that this country is facing three pandemics. We have an economic pandemic, we have a physiologic pandemic as it relates to the COVID, and we have a sociologic pandemic as it relates to racial injustice. And all of these pandemics are coalescing at the same time. So we thought it was very important for us to look at legislation and regulation. The next subcommittee group is looking at community outreach and stakeholders. They are going to have recommended a comprehensive guide for best practices on utilizing faith-based organizations so that we can really engage our community in outreach activities. We realize that there's no one better to tell the story than those who are living in it. And our last subcommittee is racial disparities in healthcare. We felt it was important that we look at the crisis of care standards for Louisiana. This is a manual. This is our go-to manual for when a crisis occurs. Well, that manual is 10 years old. So this committee is making recommendations and for modification and updates of this manual. They're also providing and exploring the concept of medical mistrust among African Americans and providing best practices. There have been some situations with racial biasness that has occurred, and we want to make sure that we address those issues. In conclusion, we know that there are solutions. We have met with health equity task forces in other states. We are in the process of forming a national coalition so that we can benefit from lessons learned and best practices. We had no roadmap when we began this initiative, just a group of dedicated individuals who were volunteering their time. You can read our full report of our task force summarization by visiting our website at www.sus.edu. That stands for Southern University System. It has been a pleasure for me to serve as co-chair. We know that this is important work, probably the most important work we'll ever have to do. And through this work, we're calling for clarity of mind, stamina of spirit, and tenacity of heart so that we can produce a meaningful change for the state of Louisiana. If we've learned nothing else, we've learned that this movement has caused us to be more resilient, and hopefully when we move out of this pandemic, we will be a healthier state for decades to come. Thank you.
Good afternoon. Thank you for the invitation and also the opportunity to discuss with all of you about the COVID-19 experience of the healthcare sector in Puerto Rico. I work for the Puerto Rico Primary Care Association, that is a nonprofit organization that supports community health centers' goals of increased access to care through leadership, technical support, capacity building, and also by fostering partnerships and collaborations at local and national levels. In this presentation, I will be sharing an overview of the community health centers in Puerto Rico, following by the experience of COVID-19 at Puerto Rico as a territory, and how the primary care sector supports that core response function as part of the emergency. Finally, has any response and new process go on without any challenges? I will discuss main challenges faced by our organization and how those best practices and innovations make a community-level response during the pandemic issue. So what are community health centers? There are nonprofit organizations that has a mission to provide access to high-quality primary and preventive care, but also they need to attend healthcare disparities on their patients that are mostly underserved. They provide comprehensive primary care services, including primary dental and mental health care, and those services are supported by a multidisciplinary team that can include health educators, health promoters, case managers, nutritionists, pharmacists, and labs also has complementary services. The goal of the health center is to provide all of these preventive and primary services centered on the main needs of the patients. So in order to do this, they address not only the clinical services, but also the social needs that they present. But what happened during an emergency, and what is the role of a community health center in that event? So because of the community focus and also the primary care clinic operating has an open door to the healthcare system, they serve as critical infrastructures during emergencies. They serve as first responders for most vulnerable and geographically limited communities, providing access to healthcare, supporting other social needs, because they have a very good understanding of the communities that they serve. At the same time that they are working with the emergencies, they should effort to continue their operation and services. They need to adjust workflows, visiting community, shelter, and looking for their patients that are not making the visit to the clinics. They also increase the development of partnerships to support the response efforts during emergencies. So in this slide, we can see how community health centers are distributing across Puerto Rico. In the map, the blue areas highlight or represent which municipality has a community health centers. So in Puerto Rico, the community health centers serve more than 425,000 patients in 2019. So that's approximately 1 in 7 Puerto Rico residents. And those services are provided by 85 primary care clinics and 110 delivery sites that include school-based programs, mobile units that are covering 85% of the island municipalities. Basically, health centers attend the most economic vulnerable populations, with 60% of their patients are Medicaid insured, 13% uninsured, and 88% of their patients are under the 100% poverty level. So how was Puerto Rico healthcare system before COVID-19? There were several issues affecting primary care delivery and also the access, including an enormous exodus of healthcare providers, mainly physicians. And the reason was Number one, to better salaries and opportunities in the U.S. mainland, and also the lack of medical residency slots for trained providers. And what happened is that once they left the island to train on the U.S., most of them do not came back to offer services on the territory. We also are seeing continuous increase in the uninsured population in the island, and this has been increased by the effect of Hurricane Maria in 2017 and the most recent emergency experience on the island. Also, there is a continuous lack of Medicaid funding to provide continuation of the program on a yearly basis, and limited certification of providers from insurance companies contracted by Medicaid under the management care model. In terms of healthcare delivery, there are high rates of chronic conditions, diabetes, high blood pressure, and the elderly population also increasing exponentially, and most of them living alone, because of family moves to the mainland. Also, there is an extreme demand to address social determinants of health among community, and as you know, in less than 3 years, Puerto Rico has been working with 3 different emergencies, including Hurricane Maria in 2017, earthquakes beginning in 2019, and now COVID-19 on this year. And from these 3 experiences, we can highlight a repeat need of social risk present at our community that reflects the disparity that before remained under the radar. More than ever, I need to address social determinants of health, increasing everyday housing, poverty, unemployment, and mental health distress are impacting our communities. So right now, what is the impact of COVID-19 in Puerto Rico? Back in March, when there is a considerable number of COVID cases in the U.S., in Puerto Rico, we were experiencing nothing like the number of cases we are seeing today. For example, last days of March, beginning in April, we have an average of 56 daily confirmed cases, and that was our peak for that season. And you can notice that in the small graph at the left of the slide. However, from July on, we start seeing a continued increase of the confirmed cases reported, and that number exponentially grows on the remaining month of August and September. Today, we have more than 17,000 PCR confirmed cases in Puerto Rico. Government was proactive back in March, making restrictions, has 24/7 lockdowns, stay-at-home orders, closure of all private and public places, and the use of masks was obligatory from the beginning. We were on that status until June 2020, where restrictive measures start to be more flexible, opening the private sector, have malls, restaurants, bars, and public offices. As an immediately result, we start seeing an increased number of COVID cases from 200 daily cases on July to almost 400 confirmed daily cases in August. Most of the cases has been reported on males and between the age of 15 to 59 years old, but followed by younger age groups from 40 to 49 years old and 20 to 29 years old. So we are not seeing most of the cases on older age groups, and most of the infections are reported among those younger age groups. That is the thing that makes us very worried right now. So during COVID-19, the primary care clinic has 2 main goals. As I mentioned before, first is to attend those emerging and evolving local needs, and also being part of the emergency response critical infrastructure. They have been critical partners supporting the response across the local level and vulnerable communities, but also they need to continue delivering high-quality care for their patients. In the rise of COVID-19, Health Center has been vital partners of the state response, conducting massive community testing. And this process not only includes simple testing, but it also involves triage patients to identify symptoms, establish points for screening and temperature checks, transform physical operation because they start installing tents, drive-through, and all of this in order to guarantee access to COVID screening and treatment, but also providing a secure environment for their patient and for their staff that look for services that are looking for services that are not related to COVID. One of the main goals of health centers supporting limited capacity of the state health department testing was a community project to test the elderly population at nursing homes. Community health centers in the island was the only provider that supported the state on screening all those elderly homes, and they impact more than 12,000 elderly in the past 3 months. Also, mainly during the first 2 months, that there is not a statewide contract in place for contact tracing. Health centers support the state performing contact tracing for their patients. As I mentioned previously, before COVID-19 hit, Puerto Rico was already facing some issues regarding the workforce retention and recruitment of medical providers. So when COVID arrived, there was a big challenge for health centers trying to retain workforce and include them in the response. For the health center, it wasn't a priority to keep those employers safe and prevent future COVID infections. They also need to provide continuous training around the clinical guidelines for testing, treatment, report, PPE, personal protective equipment, and now the use of technology has a main resource for continued care delivery. Continue delivering high-quality care in the middle of an emergency is one of the biggest challenges that the health centers face. So all the health centers in Puerto Rico are contributing to the healthcare system response, supporting the overrun hospitals by addressing the demand in care for COVID and other primary healthcare needs. They also are serving on the front lines of the novel coronavirus pandemic, and it's having a dramatic impact on their day-to-day operations, on their staffing, on their care delivery, and short and long-term budgets. So in summary, COVID-19 has demonstrated how important it is for the health centers to attract and retain clinicians to handle the current emergency and testing needs, but also to attend to the backlog of primary care needs for their current patients. And in addition to that, it's extremely important that they learn from this experience and past emergencies that they should build capacity and readiness for the next emergency or disaster on the ongoing. In this, the following slide presents an analysis of the data that community health centers weekly collect and report to HRSA around the COVID response in their clinics. And as you can see, there is more than 90% of health centers working as testing sites in Puerto Rico. And that testing site is not only for their patients, it's open for community-wide. More than 64,000 patients have been tested, and 92% of them were minorities. And almost 6 months after the pandemic started, there's still limitation returnaround time for testing for an average of more than 5 days to receive a test result back. What are the main challenges that health centers face and that affect the response in Puerto Rico? And I know that some of them are very similar to those observed on the state, but in territories, the effect could be higher to geographical limitations and also because of priority standards that are set. So this includes access to serological testing was delayed compared to the access to those serological tests on the state. Then when we were working with confirmed PCR testing, there was a limitation of reagents for PCR that continues today to be one of the main problems for PCR testing. In addition to that, FDA-approved tests that were removed from the emergency under authorization designation were tests that has been used in Puerto Rico, so there was limited serological tests at that time. Shortage of PPE has been an issue from the beginning of the pandemic. First, because the priority of distribution from the state and from vendors were hospital and not the primary care level. And after that, the new issue was the increasing cost for buying those PPE. Due to lockdown restriction and territorial stay-at-home orders that remain for almost 4 months, expectations that non-essential services be delayed, and also due to fear from the patient to visit the healthcare clinic, the results on a significant decline of patient visits for non-essential services. And that decline was around 70%. So this situation impacts workforce, where some organizations need to provide license, and some cases they need to furlough staff due to services reduction. So also if a staff present a positive need, they need to be removed and put in quarantine. So those things also represent a financial impact on health centers. For example, the higher demand for costly PPE, buying testing supplies, and in combination with visit reductions and service limitations is very, very worrying for Rico. So we are studying right now the number of the financial impact, but Capital Link made an estimate of the revenue loss of $150 million and around 1,000 employment for healthcare centers on Puerto Rico. And finally, in terms of telehealth, there are some challenges also there. Elderly populations are not used to use smartphones and new technology, and this applies to patients and also to providers. There is limited connectivity in geographical areas of the center of the island, and there is also a lack of access to internet and smartphones, especially when we are talking about the most low-income population in Puerto Rico. So, finally, in order to survive and keep healthcare delivery system up and running, they need to adapt and transform with innovative ways to perform things. So how do you overcome the challenges? In terms of a healthcare delivery, main challenge was to define how to deliver services in a safe environment and limiting disease transmission. Provide a balance between being a first responder supporting evolving emergent needs, but also keeps providing continuous care for chronic patients, preventive care, and immunization, as is the case of influenza right now. Also, to be able to identify who and where are the high-risk patients, and look for how to address their social needs as transportation, food access, social support, medications, among others. Also, emergency has COVID highlights the need to transform the way we provide healthcare education, now transforming to virtual methods. Making use of different social media platforms has Facebook to make Facebook Live, disease-focused webpage, development of new digital content under the emergency, also to make use of local newspaper radio channels to promote services and communicate the importance of continue their care and keep the preventive practices alive. This also represents several challenges to the infrastructure, where there is a demand to adapt quickly. Your physical operations has development of the drive-through, tents, workflow change, and technology infrastructure development has communications systems, equipment, and workforce training. Telehealth and telemedicine transformation under the pressure of the novel disease and emergency management was also a challenge. During its implementation, there has been some limitation as provider reimbursement remain limited at this time. Some statutory changes need to be implemented in order to ensure the consistency in payment. And also, we need to work on an extension after December 29 that all the flexibilities that have been provided in. Previous to COVID, there were not telehealth and telemedicine services offered in Puerto Rico. There was not legislation approved. We were working on it, St. Joaquin Maria in 2017, but with no results until COVID-19 arrived. And finally, our experience established non-governmental organization partnerships were an enormous value for us. Our experience in Puerto Rico during the last 3 emergencies, Hurricane Maria, earthquakes, and COVID, and our strong relationship with those organizations has been a key of providing continuity of care of primary care services on the island, but also attending the specific social needs that can limit access to care to disadvantaged communities and those vulnerable patients. So thank you so much to the Office of Minority Health for the invitation and from everyone's attention.